Good afternoon, everyone. It's a great pleasure to be here at Sick Kids, also in Toronto. Particularly, I want to thank Dr. Zulfikar Bhutta, who unfortunately ended up not being here, but was the one who was first approached me about nearly 2 years ago to try and come and attend one of these lecture series. So thank you very much to Stan and the Global Health Center here for inviting me. What I want to do today is talk a little bit about child injuries. And what I've done for the next 30, maybe 35 minutes is talk about making the case for why child health can no longer, in my opinion, ignore child injuries as a critical element of public health, particularly in low and middle income countries. So what I want to do is focus a little bit about what is the current estimate of the global burden of child injuries, where do we position that in the context of global public health, and then global child health. Are there things we can do about it? And then make the case how we might engage in the global public health arena with respect to child injuries. I want to make sure you understand that today, even though I acknowledge the huge burden that things like what we call intentional injuries, like violence and homicides and suicides, have on children, for the purposes of today's talk, I'm not going to refer to them in any detail. So a lot of my conversation is going to be around what we call unintentional injuries, like road traffic injuries and drowning and poisoning, and I'll talk a little bit more about those in detail. However, it is absolutely essential that I tell you where I come from. So for the next 3 or 4 minutes, bear with me as I describe to you that about a decade ago, we established one of the first centers dedicated to international injury prevention at Johns Hopkins University, particularly the Bloomberg School of Public Health. And like any other research center, including the one that is hosting me today, we are involved in research, we are interested in collaboration, and we do a lot of training. We believe that injury prevention is a multi-sectoral issue. So rather than trying to simplify it, we address the complexity. And we confront that complexity by using multiple strategies to think about injury prevention. So we do research of different types. We do teaching and learning of different types. And indeed, we do lots of collaborations around the world. For example, we are working in about 26 countries right now. Our intention is not to color this map blue, but rather to develop strong, sustained collaborations where there's a win-win relationship between us and our collaborators. So for example, we work with many, many non-governmental organizations because the role of NGOs, particularly in injury prevention, is essential. We work with governments and public sector, sometimes with national governments, at other times with state and local governments. We also, of course, work with the UN. We are a World Health Organization collaborating center since 2010. We have strong relationships with UNICEF, with UN Road Safety Collaboration, and different parts of the UN enterprise. And of course, like you all, of course, know, we are in the business of training and teaching. We do lots of training, both in-country workshops. We also do webinar series, and all of you are welcome to join them as and when you have an interest. We, of course, offer courses. We are involved with PhDs and masters and postdoctoral fellowships, and many of you might be in those programs here. But very importantly, we also offer opportunities for training. This is at the level of masters, at the level of doctoral training, at postdoc training, also clinical fellowships. We have surgeons and pediatricians coming to us and spending time doing research with us. So those are opportunities that are really important for developing careers which span both clinical medicine as well as research on injury prevention. But I'm most proud of our free online training programs because this is fundamentally geared towards our stakeholders in low and middle income countries. I won't get into detail, but I refer you to our website. We have a free online training program on road traffic injury prevention and control, which nearly 2,000 people from over 140 countries have enrolled. We have a new one with WHO on road safety legislation, which has just kick-started about 2 months ago. And we have now a 2-week rotating global road safety training program, which we do once in Baltimore and once somewhere out there. Our last program was in Malaysia, which is fully funded for about 60 to 70 people from all over the developing world. And of course, we publish things that you all are very, very familiar with, and these are, of course, injury-specific publications. So I think my institution will be satisfied that I've delivered an appropriate message to you all of where I come from. If you're interested, please go to our website. We have some brochures out there. But indeed, we are very open to collaboration is my fundamental message. So whether you as an individual or you as a center would like to collaborate with us, you are most welcome. But let's make the transition and talk about why should we, as public health professionals, as physicians, as clinicians, as nurses, as lawyers, as engineers, why should we be interested in child injuries? And I think the fundamental reason that we are interested in child injuries is similar to why we have an interest in any other disease process. Because it causes deaths, and we don't like that. Because it causes a lot of morbidity, we want to avoid that. It causes a lot of disability, we want to help with that. And importantly, even though, of course, the first three are critical, it causes huge losses to national and social economies. And that's fundamental. And many a times, when our health arguments don't seem to work, sometimes our economic arguments have to be brought in to convince policymakers and stakeholders to make appropriate investments. Let's talk about these reasons a little bit. This pyramid, which we call the injury pyramid, may be familiar to you from other disease processes. Fundamentally, what this is saying is that even though I will propose that our measurement of deaths from injuries still needs a lot of work, that in itself is only the tip of the iceberg. For every death that we count, there are so many others who come to the hospital and get hospitalized. There are so many more who come to the hospital and are discharged. And then, particularly in low and middle income countries, there are many, many more who never make it to a health facility, who don't get into hospital or health information systems. And those are the ones that we find out when we go out there and do community-based surveys. So even though we are making the case from a mortality perspective, we are concerned that our numbers are actually undercounting actual mortality. And of course, we are also not just concerned about death, but if you're in the field of injury prevention, you have to be concerned about morbidity and disability. Because the morbidity impact sometimes far outweighs the mortality impact, and this is true particularly in children, where with the lifespan expected, you can have decades of disability. Once again, a disclaimer. When I talk about disability, I'm talking about it from the perspective of accounting years of life lost with disability, things that we want to prevent. I am in no way, shape, or form passing judgment on people who are disabled or what they do with their lives. We are talking about metrics and the ability to prevent those things. This is really important because sometimes, unfortunately, there is miscommunication and people assume that we are talking about the value of life. So the health consequences of injuries are substantial. Some are obvious, such as the physical injury. And again, today, I will not talk a little bit about mental health consequences of injury and trauma, but many of you, I am sure, are familiar with the psychological consequences, sometimes which are acute, but some are far-reaching. And that, of course, is a completely different topic for our conversation. We recognize them, we acknowledge them, but it won't be for today's talk. But in fact, the consequences of injuries go well beyond. They go to behavioral issues. They even go to things like reproductive health. And we can come back to some of these in our question and answer session later on. But the spectrum of consequences is vast. Unfortunately, we don't have good data on all of them. And that's where our research is lagging behind our theory. The cost of injury, of course, is humongous. And once again, we have very, very few estimates of cost of child injuries. We have some estimates around, for example, road traffic injuries. The last one was done nearly 15 years ago, and an estimate of about $500 to $600 billion lost to global economy from road traffic injuries. That probably is a small proportion of the truth. Because just in the United States of America, where I come from, the estimates are already into 450 billion from injury prevention. That's just one country. That's just one country. Imagine that for the world. Imagine that for where 90% of the world's problem lies. And for every direct consequence to the economy that you can think of, in terms of the costs to medical care, the costs of ambulance, hospital care, etc., there are many, many more costs pertaining to what we call indirect costs. The loss of life of a 10-year-old, a 15-year-old, a 17-year-old, the potential economic benefit he or she could have provided, the tremendous social benefit he or she could have provided, and so on. So this is true not only for injuries, of course, but also for other conditions, but we haven't had an opportunity to really measure this. So for those of you who are currently involved in thinking about their masters or PhDs or fellowship theses, I urge you to think about the spectrum of economic analyses as a very, very important area, burgeoning area for research in child injury prevention. And of course, I don't want to give you the impression that all of these are somehow separate silos and they don't have an impact on each other. As this framework demonstrates, even though we talk about health separately and we talk about the economy separately and we talk about the family impact separately, they're all interconnected. And this is where you all, many of you, I'm assuming, are involved in child health or pediatrics, are concerned. You're concerned about how child injury displaces, dissociates, impinges on these relationships between the household activities, between family structures, between economic activities. And sometimes it has nothing to do with the child, but to look after the child, another member of the household begins to get involved. And that means that injuries are actually a source of households going from non-poor states to actually become poor. And there are very few studies that have demonstrated that injury and trauma is one of the largest causes of actually households tipping from non-poverty states into poverty states. There are results from Bangladesh, from Tanzania, and from Uganda using different strategies which these measures have implicated. But you can imagine how difficult it is to do some of this type of work. So I think I'm making the case, therefore, that if you have an interest in mortality or morbidity or disability or economics, you ought to be interested in child injury prevention. And therefore, with that assumption, let's begin to talk a little bit about the global estimates. There are two large sources of global data. One, of course, is the Global Burden of Disease data set. The Global Burden of Disease data set, for those of you who know, is from the Institute for Health Metrics and Evaluation, is not WHO. One of the biggest misunderstandings I find as I go around the world and talk is people think GBD comes from the World Health Organization. It doesn't. The World Health Organization releases data called Global Health Estimates. And Global Health Estimates have been updated for 2012. Most recently, they're coming up for 2014. GBD 2015 is out there. I'm told the GBD 2016 is also being released maybe in the next couple of weeks. So depending upon your favorite data source, the number might change, but general orders of magnitude are about 700,000 children under the age of 18 are dying from unintentional injuries. Again, I'm focusing on unintentional injuries here. These are often the leading causes of death under the age of 15. Millions of children visit emergency rooms and physician offices and get injured, and we don't get to hear about them. But what is very true is while this is important in high-income countries like Canada and the US, it is a huge issue. 90% or more of it is really in low and middle-income countries. And that's why it becomes a great concern for global child health in particular. The other thing that concerns us, of course, is the fact that every country doesn't have an equal rate, which means there is inequity in the distribution of child injuries. And what this inequity means is that it has a correlation with social determinants of health. And therefore, many times, the poor, the vulnerable, the young, in our cases, children under the age of 18, they are the ones who have a higher risk of getting injured, higher risk of being untreated, higher risk of becoming more morbid and disabled. And that is of concern to those of us in public health, because fundamentally, we are in this business because we are interested in issues of social justice. And so if we are concerned about social justice, you have to be concerned about the distribution of child injuries. It is true, as was just enunciated, that there is an age distribution as well. If you take away the first month of life, for those of you who are in the business of, for example, neonatology, certainly you take away that, injuries begin to appear as a cause of death right after approximately the first month of life. But certainly if you remove the first year of life, Then onwards, injury becomes a huge cause of death. And one of the interesting things that I've been trying to get global data sets to do is to disaggregate the under 5s into under 1 separately from the 1 to 4s. Because when you combine them, clearly and appropriately, the infectious diseases tend to dominate. But I also think that the mechanisms of injury are really important. And as you see, the older the child, the higher the proportion of those being killed and injured over time. And of course, if you look at what exactly is affecting children, particularly in this case, deaths, and this particular slide includes 19-year-olds, again because of the nature of the global data sets, you will see that things like road traffic injuries and drowning are large proportions of the child injury burden. Somehow people expect road traffic, but they don't expect drowning. I don't know what the assumptions are, but that always happens. People get surprised when they see drowning. I do want you to see, of course, that on this slide, there are intentional injuries as well, and you will see them, including things like interpersonal violence and self-harm. Again, we will talk about those, I hope, at some other point in time. But Stan, as you were talking, in fact, the disaggregated data here, you won't be able to read the slides, but just look at the green color. Everything that's green is an injury. And this is the problem that in the under 5, the green is far lower than you compare on the right side. And that's one, because the true incidence of injuries, in fact, increases the moment the child is mobile enough and gets out of the home, compared to when the child is still relatively less mobile and within the home environment. Actually, we are now doing research on home injuries in children, which becomes a huge issue, but we will talk about that, I hope, a little bit later on. And that's why when we look at the numbers of children who are injured by age group, we do find that even though road traffic injuries and drowning are leading, in fact, in the, as you can see, the 1 to 4 year age category, it's drowning that has a higher total count of deaths than, in fact, road traffic injuries, and that flips over the next 5 years. This indeed is surprising to a lot of people, and that's because we've not been good at collecting such types of data and acknowledging that drowning now is a leading cause of death in many countries, and I hope I get the opportunity to share with you a country example in a few minutes. Let me spend a minute on each one of these injuries so you get an idea. So the first type of injury we deal with is road traffic injury. Over 200,000 children die from it. These children are dying not because they are driving cars, although in some instances the 15, 16, and 17-year-olds are actually driving. I'm against 16-year-old driving, but in any case, that's the law of the land, so I can't do anything about it. But the fundamental causation is that they are on the road. They are walking, which means that they are pedestrians. They are crossing streets, and it's not their fault. The traditional attitude has been, oh, he or she crossed the street at the wrong time, at the wrong place. It actually is a system failure. Roads and road systems need to be built with human error in mind. They need to be systems such that we acknowledge that people want to cross roads, that people want to walk on the side of roads, and it is therefore important for speeds to be reduced, for construction to be done in a certain way, so that we don't lose lives on roads. And that yields itself to a very systems approach to road safety, which is the approach that we are now promoting around the world. This is an issue which is prevalent actually in both high and low and middle income countries, something that I'm sure many of you might be familiar here as well. Drowning. Now, over 350 children die every day from drowning. And this comes as a surprise to many people. In fact, what is very interesting is that a large proportion of these children are somehow between the ages of 1 and 5. That's where the largest chunk of children are dying. It's as if they are interested, curious, mobile enough, but don't have the mental capacity or the physical strength to actually control themselves when they do get submerged in water. And again, 90% of the drowning burden lies in low and middle income countries like Thailand, China, Vietnam, India, and so on. And many of these countries, it's not about drowning in swimming pools. It's drowning in open bodies of water, in ditches, in ponds, in rivers. So there is a difference between drowning in low and middle income countries and drowning in countries like yours and mine, which is fundamentally around, a large proportion of them, around controlled bodies of water. Southeast Asia, of course, is a particular high burden of drowning, and this is the area where now WHO has released for the very first time a couple of years ago a global report on drowning, and there is a movement now to try and address this as an important cause of child death and disability. Burns, something that you may have seen again in emergency room, is a problem. It's a problem particularly in those areas where cooking occurs in situations which are high risk, where children are exposed to either wood cooking or gas stove cooking, where children are around their mothers in general, and therefore this is one of those types of injuries where the rates for females are higher than the rates for males. In general, many other types of injuries have a higher rate for males compared to females, but burns is not one of them. It is flipped in this particular instance, and you can imagine why. And again, the consequences of burns are severe and can be very, very disabling. And that's why the morbidity impact of burns is very, very important to monitor. Of course, as you very well know, there are other things associated with cook stoves and indoor air pollution and lung diseases, etc., that are also interacting with our push for burn prevention these days. Falls. One of the single largest causes of emergency room visits are falls to children. And those of you who worked in emergency room probably understand why that is so. It is huge in terms of morbidity losses. Generally speaking, thankfully short-term morbidity, but on occasion long-term disability losses as well. And these are things that are easily preventable. And I know that Canada has been a leader in many instances for fall prevention programs. There are other developing countries like Malaysia, which has really latched on and picked on public health programs for fall prevention, whether it's falls from beds and cribs, or it's falls from heights or apartment buildings. These are very, very important issues, but highly preventable and highly predictable depending on the infrastructure. And something that many people get surprised is part of injury prevention, and that's poisoning. So acute poisoning is an important component of child injury prevention. Acute poisoning on the one hand is somewhat different in high-income countries, which is dominated by pharmaceutical products, compared to low and middle-income countries where things like kerosene, paraffin, oil, gas, these are all things that are stored in Coke bottles and in juice bottles, and children think that it's something to be drunk, and that's where they end up getting poisoned. And as the picture demonstrates, there is organophosphorus poisons as well that are easily available to children. And unfortunately, this is something which is being looked at very intensively, for example, in South Asia and parts of sub-Saharan Africa. Unfortunately, even though we have some products available, this is an area which needs a lot of attention in global child health. So, I'm just giving you an idea of the types of injuries that afflict children. There are many more. I'm not going to talk about every single one of them. There are animal bites. There are issues around emergency medical systems and trauma care. For those of you who are interested, I can talk to you about that a little bit later. But I do want to flip the conversation and say, look, it's a big burden. You measure it the way you want to. You can use deaths, disability, DALYs, HALYs, QALYs, your favorite indicator. I can guarantee you it's going to be a big burden, particularly in low and middle income countries. The question is, what can we do about it? And what has the global health community actually stepped in to do about it? And this, of course, stems from the fact that the loss of children anywhere has a huge impact on families and societies. And obviously it gives us a rationale to act on that, even when it does not result in a death. It can result in that lifelong disability and impact on societies and households that we want to avoid. And it's interesting that child health overall has very well established diarrhea, pneumonia, etc., very well established in the global public health community. But that is not the case for child injury prevention. Even though child injury prevention interventions are often, theoretically speaking, one of the most cost-effective interventions. What do I mean by that? As this slide demonstrates, for every dollar invested in the specific child injury prevention initiative on this slide, the returns are humongous. So if I told you, give me $1 and I'll give you $65 back a year later, you'll probably give me all your dollars. I don't know if I'll come back next year, but I will be able to give you that return. Those returns are huge. Those returns are based on reasonably good data. Maybe not the best data in the world, but reasonably good data. And you can see things like interventions that I'm sure many of you are familiar with. But unfortunately, while these interventions are available to, unfortunately, a few of us, they're not available to many, many more of us. And here's the sad story that I want you to think about. Do you know that child car seats were developed nearly 55 years ago? 55 years ago. 52 years ago, smoke alarms came on the market. 50 years ago, child-resistant containers to prevent poisoning came on the market. 43 years ago, child bicycle helmets came on the market. So we've had 50 years of interventions that are on the market. But when you go to low and middle income countries that I visit, do you actually see any of these on the ground? And that's the disconnect between our capacity to produce these interventions and our capacity to implement these on the ground. And that disconnect is what worries. So for example, the WHO 2015 Global Status Report on Road Safety says they interviewed 183 country organizations. They looked at national governments, they looked at child safety laws, and they looked at, these are laws. If you don't have a law, you can't implement it, remember? And only 53 countries in the world, according to member states of WHO, had what they consider best practice laws for child restraints. And forget about enforcement. Forget about enforcement. So after 50 years of knowing that child seats are useful for children, if you look at motorcycle helmet, there are children now in East Asia who ride motorcycles every single day. Look, it's a moot point for you and me to discuss that they shouldn't be on motorbikes. They're going to be. That's their vehicle. That's how they're going to go to school. That's the only thing their moms and dads can afford. So we can argue whether that's a good thing or bad thing, but let's make them safer. And what we want are motorcycle helmet laws that encompass children. Not available. Only 40 countries have laws that are considered best practice. So the opportunity is humongous. Clearly, we have not done a good job. Clearly, we need to do more. We need to work harder in spheres of global child health and global public health. And this decade offers us an opportunity. For example, in the area of road safety. 2011 to 2020 was labeled the Global Decade of Action for Road Safety by Ban Ki-moon with 5 pillars of action. Unfortunately, most of that work has not really focused on child injury prevention. And I will say this knowing that we are live on a webcast, that UNICEF has not stepped up to the plate. UNICEF Health needs to pay more attention. WHO is slowly stepping to the plate for child injury prevention. They are doing enormous efforts, but we need these UN organizations to really step up to the plate and talk about this, because the Sustainable Development Goals, which I'm not going to get into, but I hope you're all familiar with as global public health individuals, are a set of goals that will now determine both priorities for action and investments. And I don't know if you know that there are 2 goals that are distinctly injury prevention. One is around road safety. One specifically states that the world needs to have the number of deaths from road traffic injuries by the year 2020. That's a very visionary goal. I'm not sure we'll get there, but it gives us the momentum to invest in child road safety. And the second one is about making our settlements and our cities and our countries safer. And that one specifically mentions children and transport systems that will make things safer for children. So here are 2 examples of explicit mentioning of injuries as well as children. But frankly, many of those goals in child health will not be attainable in many developing countries unless child injury becomes a focus of attention. So let me end, if I can get another 3-4 minutes, sharing with you one example of the type of work that our center does. So in Bangladesh now, drowning is the leading cause of death for children between the ages of 1 and 4. What that means is people like you, have saved those kids from diarrhea, from pneumonia, and now you're losing them from drowning. So great job saving them in the first year of life, but we still have a lot of work to do. How do you save these children? because they are plopping into lakes and rivers and ditches and ponds right around their houses. These are not swimming pools, right? So we started many years ago, about 4 to be exact, a very large-scale evaluation. This is implementation science, implementation research, designed to determine what might save these children. And we called it the Saving of Lives from Drowning, or the SOLID project. And we wanted to estimate the effectiveness as well as the cost effectiveness of 2 packages. One, we actually looked around for appropriate field sites, and we had 7 districts in Bangladesh where we distributed this. Many of you might be familiar with some of our partners, the International Center for Diarrheal Disease Research, or ICDDRB. Many of you, I'm sure, have read 50 years of work in global child health, and the Center for Injury Prevention and Research in Bangladesh as well. Both of them helped us, and basically we established a quasi-experimental design where we enrolled children. We gave them either an intervention that was around community creches or daycare centers or playpens. Playpens, yes, the same playpens that many of you may have been in many, many years ago, or for those of you who have children, you might be using for your children. And the idea is that when mothers and fathers are so busy that they are not directly supervising their children, the child has literally a minute or 2 minutes and walks 6 feet, 8 feet, 12 feet, and drops into a ditch and a pond in a situation like Bangladesh, which is a delta where every house is built because you excavate land and that then gets filled up with water. So these interventions were evaluated. I'm not going to go into the details of the study design, but simply to say that it was not an RCT, but a quasi-experimental design. We also had lots of community mobilization, getting unions and village councils involved in injury prevention. We established these injury prevention committees. We actually gave out different types of playpens. We looked at community creches. We established a whole demographic and surveillance system where community health workers went out every 3 to 4 months and inquired about any injury event, any death in the household, any child who had fallen into water. So we have tons of data on that. We covered about 1.2 million people. This is a humongous study. We covered nearly 75,000 children were enrolled in this. We established over 3,200 daycare centers. We had over 50,000 playpens distributed, and so on. And we are very grateful that Bloomberg Philanthropy has sponsored this particular study. Since the results of the study are under peer review right now, I am not able to show you the real results, but I'll give you a flavor that the all-age injury and drowning-specific mortality as we followed these populations seemed to be going down every single time we looked at it. Across all ages. This is not just children. This is all injuries. It's very interesting. Think about daycare centers. Think about if children are safe. Are they safe not just from drowning, or they're safe from all types of injuries? And actually then we homed in on the ones that we were particularly interested in, and it seems that the both injury and drowning specific rates were going down as well. Again, my apologies, but because of peer review, I'm not going to reveal the actual final results, but this is very exciting. Many of our publications, particularly from our baseline work, are already out there for those of you who are interested in the American Journal of Medicine, in the International Journal of Environmental Research. If you're interested, please read up on it. And I hope in the next 2 to 3 months, you will see our main results coming out as well. So that's an example of the type of work that is now needed. Ladies and gentlemen, I have been in this field for over 20 years. I've been calling for work in child injury prevention, and Dr. Bhutta knows about this. I've been badgering him for a long time to become interested in this field. I've been talking about how we need to work on this issue. Child injuries are preventable. There is no doubt about that. Child injuries are predictable, so you know what are high-risk situations. And actually, high-income countries, as demonstrated in this graph, have done it. So Sweden and Norway have done it, the US has done it, Canada has done it. There is no reason why low and middle income countries cannot do it, except that we have to make it a high priority, high investment, high action agenda. And that's fundamentally our mission. I hope that you all will begin to understand that we need a comprehensive approach to child injury prevention. It cannot be part of other things that we do. It has to be specific. It has to be specific to children. It has to be specific to this plethora of conditions that we call child injuries. Health systems have to become familiar with it. We have to collect appropriate data. We have to do appropriate research. And this entire gamut of work is really, really important. And I hope your center becomes involved in this work.
What became obvious to me in looking at your numbers, whether they're Seattle numbers or Geneva numbers, is that when you look at the number of children being affected by unintentional injuries versus most other things, one would think that it should be on everyone's top agenda. Is there any low-hanging fruit here? How could we make it on everyone's agenda?
Yeah.
Or not everyone's agenda, but perhaps the countries where the burden is the highest?
One of the things we've been thinking a lot about is why is it not on the global child health agenda? And there are many reasons which one can hypothesize. I believe that one of them is the inability of, frankly, the medical and health community to recognize injuries as part of their agenda. So it's really easy to understand when your disease is caused by a bacteria, a virus, or a protozoa, right? So TB or malaria, you know the bug, you know why it goes through. But if I tell you that energy is the causative element for injury, then you become all confused. What do you mean energy? Well, it's kinetic energy. And that's what happens when kinetic energy passes between the car and the child at that point of impact on the road. And that has caused, I think, some challenges with the medical and public health community. The second one that I think causes issues, particularly in ministries of health, is that when you speak to them about a particular injury, they will always displace it to another sector. So you go and talk to them about road traffic and they will say, oh, that's a police issue. It's got nothing to do with us. And you sit there and wonder, well, human beings are being injured and killed and so on, and what does that mean? When you talk to them about drowning, they will talk about in the environmental sector. They won't talk about what is important for them. So in some ways, it is both an opportunity but a challenge for us, because fundamentally, injury prevention is intersectoral. Easier talked about, very difficult to do. And I think that's both an opportunity and a challenge, and I think we too have to become better at enunciating that and putting that forward, both in terms of policy making and investments.
Thanks very much for that. I have two questions.
Sure.
The first is about the gender disparity in rates of injury. I was just wondering how that might translate into injury prevention strategies, if that's sort of factoring in. The second is about sort of framing this in economic terms and thinking about sort of broader economic losses related to productivity or absenteeism. So those are sort of losses at the societal level, but then thinking about how prevention strategies are sort of, they create costs at the individual level, purchasing a helmet, for example. Are there any attempts to sort of subsidize those sorts of individual expenditures?
So thank you very much for both of them. On the first point, first let me begin by saying that when we talk about gender disparities, it is extremely important for us to understand that there is a gender disparity fundamentally in reporting data. So when we talk about gender-specific rates, we have to always remember that have they been reported appropriately, because there is literature that says that fewer females who are injured get reported in data systems than males. But with that assumption aside, you're right that I gave burns as an example where female rates are higher than male rates. If we look at other things, for example, suicides, that is also true in many, many instances. But that doesn't mean that the impact on a particular gender is less. Because in fact, what happens is, let's take road traffic injury. Very, very high rates amongst males compared to females. But what eventually happens is that if a male 35-year-old dies on the road, he, if he particularly happens to be the breadwinner, leaves behind now a female, let's pretend 4 children, and that entire family unit and that burden now rests on the female head of the household effectively. So I always like to make sure that we qualify the fact that this is a gendered issue, but for both genders. There are implications for the incidence rates on males in many, many injury instances, but the impact of these rates can be felt in the other gender as well. And that's why we think that this is really important for those people who are interested in gender studies. And of course, this is different for intentional injuries. And for intentional injuries, I can have a different conversation about violence, suicides, interpersonal violence, and what the implications of that are. On your second point about costing, I think you're raising a very important issue. The first issue is, what is the economic impact of a particular disease, in this case an injury, on society? And that, you appropriately indicated, we can do the direct costing as well as the indirect estimation. But when you talk about the economic cost of the intervention, then you are in the business like any other intervention. So let's take malaria, bed nets. Is the household going to pay for the bed net, or is there a national program for bed nets? Similarly, is the individual going to pay for the helmet, or is there a national program for helmet distribution? And I think that's, as public health has taught us, the initial costs are always high, mass production reduces it, local production reduces it, but the key thing also is not just the supply side, it's the demand side. Communities have to want these interventions. And even though there are studies out there that demonstrate, at least qualitatively speaking, that certain types of individuals may not want to wear helmets, the fact of the matter is, when you have a law which is appropriately enforced, then many of those barriers can be broken. So it's a delicate compromise between supply and demand. As we found in Bangladesh, for example, for our research study, local production of playpens was about a third cheaper than buying playpens from anywhere else in the world. And I think that's what we have to do in injury prevention, is to go down that pathway and begin to think about national programs. But thank you. Very important questions.
Thank you very much for the great presentation. A question, any comments on the rural-urban divide? I guess there'll be more road traffic injuries in the urban setting than the rural, and more drowning on the rural setting versus the urban?
So thank you very much for asking the question. I think the rural-urban differences are variable across the different types of injury. Many people in the early years expected urban rates for road traffic injury to be higher. Actually, the rates for road traffic injury are higher in many countries in rural areas. And that's because in many of those situations, speeds are higher. And the construction is such that you have single-lane roads that allow high speeding with very little protection. And that's why the rates of fatality. The second, of course, is when there is a crash at high speeds, the probability of death is higher, and the ability of any form of emergency medical system to get to you is lower. And that combines with a high case fatality rate in rural areas. In the case of drowning, you're absolutely right. The rates are higher in many areas of the developing world for drowning rates in rural areas compared to urban areas. But that is not to say that urban drowning doesn't happen. It is a phenomenon. Even in countries like Uganda or Bangladesh, urban drowning is reported, but the rates certainly are lower. I think one of the things that we have been trying to struggle with is, in order to have those differentials, urban versus rural, we have to have some form of reasonably good data. And that's part of why the push to do national injury surveys has been going on. So over the past 20 years, a number of countries have had national injury surveys. These are nationally representative samples, and we have been able to look at this. But to be honest, the attempt now is to latch on injury modules to, for example, DHS surveys, demographic and health surveys, or if a national health survey is going on, you add an injury module to that, which wasn't done before. So we didn't have good estimations on a regular basis, and I hope that more and more countries will actually add those modules so we get better data on that.
What kind of inequality you have found in research between the child injury between the higher income and the low income countries?
Inequality?
Yeah.
I see, okay.
And the second question is that there's a very good results that you're finding out that your interventions, and I feel lucky because I'm from Bangladesh, so I know how crucial it is. So what is your actual interventions really works right now to declining the rate?
Yeah. So thank you very much, and glad to have you in the audience that I spoke about your country, and I'm not from Bangladesh. So the first point is your question about inequality in research between high and low and middle income countries. I think that the research enterprise overall, as you know, in injury prevention is highly underfunded compared to many, many other disease conditions. So we claim that funding for injury research is really like an orphan child right now. And most of the money tends to flow, we recognize appropriately sometimes, to infectious diseases and other conditions, but we hope that the non-communicable disease agenda, which is inclusive of injury, gets a higher prominence. Right now, very few donors have taken this up. There are very few calls, for example, at the NIH even. Grand Challenges Canada has had a couple of projects only, but very few, very minor. So I hope that all of you can mobilize certainly Canadian resources, but we are trying to see if both global research donors open up their agendas to child injury research. What I think is also important is to make sure that countries, national research councils, national medical research councils invest in injury research at country level as well. And I think that's also important because they have a responsibility to respond to their burden. So I think there is huge inequality right now between high and low and middle income country. We want to correct that, but we also want high income countries to invest in research on injury in low and middle income country. And I've been fortunate that I've had funding from NIH for LMIC injury research, and that's part of what we do as global health researchers. I think your second question is really important. I think the interventions, which are fundamentally social interventions, like a daycare center or a community creche, are challenging because they are not as simple, if to the extent any intervention is simple, like a vaccine or a bed net, but they are about bringing the community together, having a physical space, having the community agree to sending their children for 4 or 5 hours a day, having a creche mother who is not only looking after them, but also trains them. There is a training curriculum, an educational curriculum, somebody to assist her if there are too many children, and so on. So it's a complex social intervention. And this will be quite challenging to replicate. And so what I think hidden in your question is an important challenge for us, which is that interventions like those will be difficult to replicate. But that is a difficulty we have to confront. And actually, we have now started in phase 2 our sustainability planning. The ministry in your country, for example, both the Ministry of Health, but also the Ministry of Child Welfare is involved. Many NGOs are involved. The UN agencies are involved. Foundations are being involved. And now we are hoping to export this model to at least a few other countries like Vietnam, Thailand, and Philippines. So initial pilot projects are ongoing. But it's a really important question because unless we do that, the world's children are still uncovered and unprotected.
Actually, this kind of follows up on that question. Can you comment, it appears like when you look at the injury research that is available, there's a lot that's been done in terms of descriptive epidemiology. We've established the burden is extremely high in low middle income countries, but what's interesting to me is it's one of the only diseases that is actually affecting high income countries and low middle income countries. And there's nothing else like malaria. We don't see a lot of that here. But could you comment on the lack of good evaluation studies? We have very few RCTs. We have they're almost non-existent. A little bit of quasi-experimental, but you develop these programs, and there's very little in the literature that actually provide some good evidence base for the injury prevention program.
So thank you very much for raising that point, which is, I think, my major concern and my challenge to the research community. So when you think about intervention studies in the injury field, there are 2 or 3 different domains of work. The first domain of work is interventions that have already been shown to be effective. Think of a helmet program. Now, we don't need to demonstrate that helmets are good to prevent head injury. That's already been done. So in this domain, you have another problem. So if I want to do helmet program in Uganda, I can't have a controlled population. That's unethical in many, many different ways. You can't not, because you've already proven that helmets are good for heads. So you then get into the realm of implementation science and implementation research and different types of studies that are equally good, but for a different purpose than RCTs. Second domain is situations like drowning in between 1 and 4, where existing interventions weren't available. So nobody had talked about drowning in the home setting within 20 feet of the home living room. And therefore, the development of new interventions was really important. And so that's a domain where new interventions need to be developed. And increasingly now, with technology, for example, we have another study ongoing in Malaysia where we are looking at a mobile health application for preventing child injuries in the home environment. Now, that study is a cluster randomized study. And so we are able to use that design because of the fact that it's a new intervention. And the counterfactual is not killing people, right? So that's very important that we have an appropriate control for those situations. And I think for new interventions, we have that opportunity depending on the ethics of a particular research. I think the third domain is very much when national governments agree to roll out large programs, as we did in many, many instances of other areas of child health, where some of the studies came with IMCI, or the Integrated Management of Child Illnesses, where you had countries rolling it out, and many colleagues, both from here and from our university, studied that as national programs were rolled out, but nested designs in there and were able to give more information. I think the child injury research agenda around interventions is up for grabs. Unfortunately, there aren't enough donors doing RFPs, which is partly why I think you don't see research. I think younger researchers, as I am, trying to stimulate them and trying to mobilize support for doing that research. So I think it'll be a mix of demonstrating that good research can be done, but different types of research maybe than the traditional individual-based RCTs that were always done for child health interventions. But thank you, that's a very, very important area.
Thank you very much. I'm going to just make some final comments.
Thank you.
So I'm sure you'll agree that the combination of Dr. Hyder's academic approach and passion is what we need to solve problems like this. But I'm phenomenally impressed with, maybe I should use your focus or your stubbornness to continue to work on this as a hugely challenging issue. And as you say, it's challenging because unlike those of us who work perhaps more in the health or biology area, where if I'm working on vaccines and I want to convince someone that vaccines are important, I only really have to deal maybe with two ministries, the Ministry of Health and maybe the Ministry of Finance, but two at the most. And I think one of the challenges around injury prevention is that if you think about it, even in a Canadian context, a lot of individuals who are responsible for the health and welfare of people in their country and community would say, it's actually not my problem. It's your problem or your problem. And it isn't perfectly clear when I think of road injuries whose responsibility it is. And the answer is, it is a group of individual ministries or people's responsibilities. And when you're dealing with more than one or two ministries or organizations, then the challenges of implementing something become all that even harder. So congratulations on your passion, your focus, your stubbornness, and what sounds like an incredible organization that you're running. Please keep it up, and please come and visit us again. So thank you so much.